Bismillahirrahmanirrahim. Assalamu alaikum. Today we will talk about a motility disorder of the esophagus, and this is called as cardiac achalasia, in which there is no relaxation of lower esophageal sphincter when the food bolus arrives at the lower end of the esophagus. This is called Achalasia Cardia or cardiac achalasia. Synonymously, this disease is also called as cardiospasm or megaesophagus. Some people call it as esophageal dystonia. Achalasia is a Greek word which means does not relax. So as the name indicates, this is a disease of unknown etiology in which there is loss of peristalsis in the distal segment of the esophagus with failure of lower esophageal sphincter relaxation. Normally, this lower esophageal sphincter is contracted, but on the arrival of the food bolus, it relaxes and then the food bolus passes into the stomach. But here in cardiac achalasia, there is failure of this relaxation so that food bolus is pent up, as you can see in this picture, and it does not pass on to the stomach. So this causes obstruction at the level of gastroesophageal junction, and both of these abnormalities will lead to impaired esophageal emptying, and food will be pent up there in the esophagus, causing the dilatation of proximal part of the esophagus. This is a primary esophageal motility disorder. It is also called as cardiospasm because there is spasm of circular muscles of the lower end of the esophagus, and the contracted segment does not relax so during swallowing, and it will lead to dilatation, tortuosity, and hypertrophy of the esophagus proximal to that. So there will be abnormal dilatation of the esophagus, as you can see in the picture also, with lower esophageal sphincter is still tight, contracted, because there is degeneration of those neurons which say no to this contraction. Loss of ganglionic cells in the MYENTERIC plexus, distal to proximal. From lower side it starts and gradually it goes upwards, and basal lower esophageal sphincter pressure, it is naturally rises. It is common in adults around the age of 25 to 40, only 5% in children. It also occurs in elderly in association with malignancy. Esophagus, we know it is a muscular tube. In adult, it is about 25 centimeter long, starting from the lower end of the esophagus up to the gastroesophageal junction, which is at the T11 level. And it has got 4 layers. From inside, it is mucosa, then submucosa, then there are muscularis externi, in which there is longitudinal and circular muscle fibers, and outermost layer is the serosa. As you can see in the picture, that outermost is the serosa, then longitudinal muscle fibers, then circular muscle fibers, and in between longitudinal and muscle fibers there is neural plexus here, and then is the submucosa, then is the muscularis mucosae, then is the mucous membrane, that is the lining epithelium is stratified squamous epithelium. You can see that this is the longitudinal muscle fibers and these are the circular muscle fibers, and neural plexus is lying there, which is what we call as MYENTERIC plexus. It is lying here in between these 2 layers of the muscles. Peristalsis, from your physiology knowledge, you must be knowing that it is a wave-like contractions of the smooth muscles of the esophagus that propel the food contents onwards by alternative contraction and relaxation of the esophagus. As you can see in the picture, that food bolus is going on. Behind the food bolus, there is contraction of these muscles, and the fibers, circular muscle fibers which are distal to the food bolus, they relax so that food gradually is passing and ultimately reaches up to the lower esophageal sphincter, which relaxes in uh, in reception of this food bolus so that it can pass on to the stomach. Then there may be two food boluses, three food boluses in whole length of the esophagus. What will happen behind this food bolus? Contraction. Here will be the relaxation. Then here will be the contraction, and here will be the relaxation, so that the second food bolus is passing on, and then this food bolus will be taking its place. So this is a peristalsis. And achalasia, it is characterized by increased lower esophageal sphincteric pressure due to the degeneration of those nerve fibers who says no to this contraction, leading to the decreased or absent peristalsis in the distal portion of the esophagus, and there will be lack of lower esophageal sphincter relaxation in response to swallowing. So there will be stasis of food there in the esophagus. It is not passing on to the stomach due to the contracted lower esophageal sphincter, which fails to relax. MYENTERIC plexus, it is lying in between the longitudinal and circular layers. Acetylcholine and substance P are the excitatory neurotransmitters which causes the contraction of the esophagus, while the nitric oxide and vasoactive intestinal peptide VIP are the inhibitory neurotransmitters and responsible for relaxation of the lower esophageal sphincter and coordinated esophageal peristalsis, which are degenerated in cardiac achalasia patients. So MYENTERIC plexus, it provides both motor innervation to both the muscular layers, that is longitudinal and circular, secretomotor innervation to the mucosa, and it controls the esophageal motility. So exact cause of this cardiac achalasia is not known, but it is assumed that there is degeneration of the MYENTERIC plexus so that there is a loss of inhibitory neurons, which allows unopposed stimulation by the cholinergic neurons, leading to the failure in lower esophageal sphincter relaxation and absent peristalsis of distal esophagus. Inflammatory degeneration of the neurons in achalasia, it is not confirmed or not known. It is associated with HLA and DQW1, so they say that it may be an autoimmune disorder. In a study evaluating T cells in the patients, achalasia found reactivity to HSV1, that is herpes syncytial virus. So it may be, they said, that achalasia triggered by this HSV1 infection. Causes of secondary are pseudoachalasia. There are different diseases which can cause this. One is Chagas disease, which is caused by the protozoa parasite Trypanosoma cruzi, in which there is a loss of intramural ganglion cells. Then malignancy in the lower part of the esophagus, either by invading the esophageal neural plexus directly or indirectly through the release of uncharacterized humoral factors that disrupt esophageal function as a part of paraneoplastic syndrome. Then diseases like amyloidosis, sarcoidosis, neurofibromatosis, eosinophilic gastroenteritis, MEN type 2B, which is multiple endocrine neoplasia type 2B, juvenile Sjogren's syndrome. In pseudoachalasia, certain features they will indicate that the patient may be having malignancy underneath. If duration of symptoms is less than 6 months, presentation age is old age above 60, excessive weight loss in relation to the duration of symptoms, and difficulty of passage of endoscope through the gastroesophageal junction. So that should lead to that the patient may be having malignancy. So pathophysiology, now very clearly you can understand that MYENTERIC plexus is the one which is affected, may be affected by inflammation, or by it is the damage by malignancy or any other factor, so that there is loss of inhibitory ganglion cells in the MYENTERIC plexus, which lead to the neurotransmitter inhibition, like nitric oxide is decreased, so that there is imbalance of nitric oxide and acetylcholine, and there is failure of relaxation of lower esophageal sphincter, leading to the cardiac achalasia. Annual incidence is approximately 1 case per 100,000 population. Younger patients around 20 to 40 years of age are usually affected. Females are more prone to get this as compared to males, with the ratio of 3 to 2. In some studies, they have claimed that there is equal distribution in both sexes. Patients typically experience symptoms for years before seeking medical attention. So there is dysphagia is the presenting symptom, and it is more for liquids to start with, is progressive and worsening, and of course may lead to weight loss. Patient may claim of chest pain, which is induced by eating, and it is retrosternal, so that it has to be differentiated from cardiac pain. Infected teeth and gums due to acid reflux, fermented food, and poor orodental hygiene in such patients. Regurgitation of undigested food, some patients learn to induce it to relieve the pain. Heartburn will be there, sensation of food sticking in the lower esophagus, and nocturnal cough. Later on, there will be, due to recurrent aspiration, inhalation of refluxed contents leading to pneumonia, and of course weight loss depending upon the duration of symptoms. So triad of cardiac achalasia is that it is dysphagia, more with the liquids to start with, and this will lead to weight loss, of course, and regurgitation. Its staging is depending upon the dilatation of the proximal part of the esophagus. If it is less than 4 centimeter, it is stage 1. If dilatation of proximal esophagus is between 4 to 7 centimeter, then it is stage 2. And in stage 3, the dilatation will be more than 7 centimeter. So in part 2, we will continue with the investigations and treatment of this. Thanks for watching.